Hello, and welcome to Ethics and Moral Problems. My name is Dr. Stephen Bujno. This lecture is on ethics and guidelines, principlism, and professional codes. So this will be the last of the actual lectures that deals with the foundational ethical, let's say, systems. We will soon enter into speaking specifically about various moral problems where we'll be able to apply this and also our understanding of the human person. Now, we've hardly exhausted the extent of the ethical systems that we've covered. What I presented was a generalization of the understanding of each ethical system and perhaps ethical thinker. And there's also ethical systems and other viewpoints that we have not even covered, which only makes the point more visible that this ethical evaluation requires some foundations prior to judgment. At the very least, it should be impressed upon us that it's not an easy thing to simply know what it is that we should or should not do. Now, the distinction here is with these guidelines is that when we develop principles in order for us to follow and protocol, we're typically talking about professional environments. In the case we'll be looking at with these four forms that constitute principlism, primarily in medical ethics. Now, the reason that principles have, let's say, a strength is that there's always this tension between these theories of ethics and how we apply those. So, between the theoretical and the practice, there's always something there that doesn't quite seem like it just meshes perfectly. So something needs to be varied out about that. The reality is this is even more so necessary with principles because in a pluralistic society we share quite a differing values and such. So we can't just look for the lowest common denominator. But we do have to have some sort of standard that enters into the equation and helps with our ethical evaluations. I do want to mention that if it comes across that because the average person knows very little of ethical theory, therefore they are not ethical, that's a fallacy. A person can be ethical without having a particular expertise in ethical theory. But it also is clear, or should be, that how one forms those judgments and ethical theories are not always clear to the individual. This requires a little bit more reflection. So we're not trying to say that simply because somebody cannot articulate their ethical theory that their practice is unethical. But it would be good, at least as far as ethical consistency is, if that we all were able to determine what exactly forms our ethical judgments and then apply that across the board. You've noticed already that there's quite a bit of distinctions between the ethical theories that we've been looking at, which means that they conflict. Deontology is the nemesis of utilitarianism. Virtue ethics is more so something that is going to govern the human person as they are, like we said, in being. Justice and fairness is a way to apply some ethical, let's say, justice as fairness, as being the standard to a pluralistic society. And here with these principles and protocol, we're just trying to give people guidelines to say this is how you act in a practical application. So it's a way to deal with the diverse ideals and values and not necessarily undermine them, but also not simply looking for the lowest common denominator. The reality is that all professional applications of ethical judgments are going to have some legal implications. Those legal implications, although they themselves should be based on ethics, even though they don't form the ethical opinion, nonetheless become a consideration in the principles and protocols. In other words, if there are particular legal findings that have been adjudicated in any sort of civil or criminal court setting, that's going to have an impact on how individuals practice their professional positions. So we cannot get away from them. Let's put it that way. They're part of this whole discussion. So these three things, generally speaking, are what we're going to fold into our understanding of principles and protocol. And then we're going to say that those principles and protocol are that which will help us govern our behavior. So to principlism proper, there are four principles: autonomy, beneficence, maleficence, and justice. We'll look at each of those individually. But these are particularly applied in medical ethics to regulate behavioral norms in any professional medical setting, whether it's we're talking nurse, physician, EMT, home health care. All of these would at least be something that could be put into practice. So it's an attempt to take the theoretical and to put it into something concrete. The first one, autonomy. Now that's a popular word term in our culture. It's not the same thing as liberty. So liberty is my ability to do that which I would like to do. So freedom to do something, non-constraint. And any then constraint on my freedom seems like a lack of liberty. And that's not quite the same what we're talking about here with autonomy. So it cannot be simply self-determination. In other words, autonomy cannot just be in the medical application of a patient wanting to do what they want to do. There's limits for the good of care to the community and limits to the good for the care of the patient itself. So autonomy has a certain level of self-mastery. In other words, it should have a reflective aspect to it that the patient brings to the occasion. Now, I want to say something real quickly here as an aside. I'm not a medical professional, and I would even garner most people listening to this lecture are not medical professionals, but we are patients, or have been, or will be. So it's very important that we understand the ethics that is the primary guide and protocol for our treatment, which is why this is important regardless if you are not a medical professional. So this idea of autonomy, at least the way it's presented here in Principlism, comes from Kant's categorical imperative. Now remember, there are two categorical imperatives. The second one is the one that I'm emphasizing here. So it means that nobody can use a human person as a means to an end. So a human person can only be used as an end in themselves. If you want to think about that in practical terms, you cannot simply do whatever test or studies on an individual to get to a good conclusion, because that would be using the individual without their consent for something that does not include them as the purpose of the actual study. All right? So maybe in that regard then, it's best to not think of this principle as simply autonomy, but think of it more in terms of respect for the patient's autonomy. So there is a certain dignity that's based, and this is where Immanuel Kant gets it from, the dignity that's based in the fact that they are rational human persons. And a rational human person should use their reason in order to guide themselves to their goals. So autonomy is to respect that patient reaching their goals. And that's a better way to hear the words autonomy. So I don't want you to think of autonomy as simply an independent choice. That's what they want. It has to be more than that. Think of it in terms of an informed choice. In other words, has the individual at least been given the opportunity to come to their own conclusion based on information that they were able to digest and in some way put it all together and form a decision? And that decision has to be voluntary. In other words, respect for autonomy to make sure that family members are not unduly influencing them, or that even the medical professionals, for whatever reason they might have as an ulterior motive, that they are not unduly influencing the patient. Now, there's always concerns with every ethical system, and I'll give concerns for each of these principles as we move through these. A basic concern, which will be applied to each and every one of these principles, is that they conflict with each other. So autonomy, this respect for a person's informed choice, could come up against beneficence, the physician and medical professionals wanting to do good. So you can imagine like an EMT showing up to a situation where the individual is being combative, and you're trying to assess how can I get this individual care and still respect their autonomy. So certain, let's say, modes of persuasion are going to come into effect. If we were to take autonomy to its nth degree, well, then the patient would have to be left on their own. Apparently, they're combative, and I'll assume from their combative nature that they don't want care. That would not be in the best interest of the patient. So it's a respect for that person's autonomy. And we're going to have to find a way to make this work with doing good, which we'll see what that's about shortly. Now, this autonomy, which is the patient is looking for some good within themselves, how is that good identified? So people have different goals, and even if the goals are reasonable, if we're not just leaving it as an independent choice, even if the goals are reasonable, across cultures, these things could change. So you can think of in some cultures throughout the world where they would have female circumcision to remove the sensual pleasure of sexual intercourse from a young girl. That particular culture might find that as good and an expression of autonomy. In the Western world, and in Western medicines, particularly in the United States, it's not acceptable. So we got to make sure that whatever good is being chosen is not reduced simply down to self-determination. In other words, again, this is what I want. And finally, autonomy is never absolute. A person cannot self-harm. They cannot harm others. Everybody's autonomy stops at the threshold of another human person, which is why it's very critical that in ethics we understand exactly what constitutes the other person. Okay. Now, if we go on to beneficence, just like a misunderstanding with autonomy, this is to do good for the patient, but it can be wrongly thought simply to do what is good for the person in their view. So again, that's going to be an issue that we'll have to address. Now, when a healthcare professional is trying to do good for the patient, and whether there's a procedure coming up or a particular let's say, study that they might enter into and determining their consent, it's not enough to simply give them all the options. Now, the reason why, let me be clear about this, is that it sounds good in principle, perhaps, at least on the surface, that if an operation is coming or you have this pathology, this would be a better way to say it. If you have this pathology, and there might be 6 or 7 different options, it's not required that the medical professionals lay them all out. What would the average patient do with that? Could you imagine going to a mechanic and having them tell you, well, I could do these 6 different things with your car? First of all, you want them to narrow it down. So the medical professionals will probably give some sort of consensus on these are the best approaches, and there'll be some burdens and benefits that come with each of those choices. So this isn't just choosing from all the options that are available. What it does, though, is every patient, they have their particular norms of what they think are important. We all have various dispositions, psychologically, spiritually, and such, and there's all various actions that we would accept to, let's say, move towards the goals that we have. So all those have to be taken into consideration. These are the internal beneficence of the patient. Also, whatever it is that this good to be done for the patient, it is always directed towards not just them, but the well-being of others. So we're not singulars in the world, and there's never just one patient. Allocation of resources may sound crass sometimes, but at some point it's a reality, as is people's times. So you could imagine that there's only so much time a physician or a caregiver or a nurse or first responder is going to have to deal. So they will have to not just be efficient, but they'll also have to be considerate in justice to the other things that is required of them and other people who might need their services. So this is the basis of beneficence. We'll say again, conflicts with other principles. So we can say, particularly with this, that if we're going to look at justice, which we will shortly, then we have to do good to not just one individual, but to all. And we're here to, again, to ask the question, what is this good that we are identifying? If beneficence is to do good for the person, then what exactly is this good? I mean, is good determined for what's best, what's easiest, what's less expensive? again, economics is part of our health care. So that is a consideration in all things. It's a shame that it has to be, but I think even with universal health care, there's still going to be allocation of resource questions. Now, the concern is that if a medical professional did what they thought was best, which is what is being asked here, well, I should say it this way, they're asked to be beneficent towards the patient, but if they basically reduce it down to what's best, then that would take away agency or the free will of the patient. And what this is paternalism. In other words, the doctor will determine what is best. In other words, the patient is unable to do that, so the doctor will do it. This is a gross, and even if it was an historical misunderstanding of the application of beneficence. So it cannot just simply overcome the patient's will, because that will simply devolve into paternalism. Something just to mention here real quick is that we know that not everything can be cured. We know that many people live with chronic illnesses. Well-being is not the absence of every pathology. In other words, people with chronic conditions, even terminal conditions, might consider themselves well. A person with diabetes understands what their particular diagnosis is and how to treat it, but they don't go through their life considering themselves unwell. So not all options will lead to cures, and not all patients will choose the cure. This, again, is going to be the conflict with autonomy. Some patients will, in all ethical means, withdraw from particular treatments, and that seems to go up against the professional who wants to do good for them. So let's not equate well-being with cure. Just something to reiterate again. Non-maleficence is to do no harm. Now, when I say this is not equated with performing heroic acts, an analogy is going to work well here to explain that. If you were in an apartment building and it were on fire, I know that we would grab some things and perhaps those close to us. Well, let's say we did that and then we got out safely, but we see the building slowly engulfed in flames and we know that there's other people that are in there. There'd be a heroic act for an individual to go back in for those and to risk their own life. That's not required ethically of individuals. We have a natural inclination to preserve ourselves and to have reasonable care for those around us, but we may not and are not required to jump into a raging water to save a poor individual who has slipped off the bank into the water. So not doing harm is not the same as making sure that no harm comes to anybody. I just want to lay it out that way. Also, when you're trying to do no harm, let's make sure that we don't think some illicit means will be the manner upon which we get to that worthy goal. So we can say maybe a little more clearly that non-maleficence is the prohibition of causing injury or harm to another. So the reality is that this is going to be a term that we'll have to sort of work through, because you'll see when we talk about the concerns of this idea of what is or is not harm is not unlike the idea of the term what is or is not good. But let's say that a person is unconscious and there's no proxy nearby and there's no understanding of what that individual wants. Non-maleficence governs the care of any non-autonomous being, whether that's an individual who is not emancipated yet. So if a 14-year-old needs particular care, it's just going to be done. If a young person has cancer and it requires treatment pronto, the parents don't really have a choice to not do that. The principle of non-maleficence says we cannot do harm to this child, and doing harm would be allow that cancer to be untreated. In emergency situations, this also applies. So nobody can go to the emergency room or be found with a broken leg and simply refuse to have it fixed. That's not something that's going to ethically be allowed. And if any of us were unconscious, then the principle of non-maleficence is what fits into the actual practice of the protocol. So at that point, we're in a sense non-autonomous, even if it's only temporarily. We'll leave it here that, again, this conflicts with the principles. And I'll just restate that in the same way that there is ambiguity in the term good, there's ambiguity in the term harm. In other words, here's an example. Speaking about euthanasia, as opposed to somebody on pain medication who is slowly dying, is letting somebody die causing harm? Or if we give them some sort of pharmaceutical to hasten their death, is that causing harm? You can think in terms also of the beginning of life issues. For some people, abortion is beneficence. For others, it's causing harm, and then the principle of nonmaleficence would chime in. So these types of things have to be worked out in practice, but this is where other ethics, at least ethical systems, are going to have to come into fruition to make up the gap. Now I want to say something before we move on to the last principle, and then I'll just real quickly talk briefly about professional codes. When you're trying to determine what exactly is the thing that we are doing, moral fonts apply. So there are three moral fonts. There's the object, this is the goal, the intention, this is the, well, let's say it this way. The object is the what am I doing? The intention is the why am I doing it? And the circumstances are the who, the what, and the when, and the where, things like that. Now, how this would apply. So in the case of, say, comparing euthanasia with allowing somebody to die, or giving pain medications, even if it hastens death, let's put it that way. The intention's always the same, so it's to end suffering. So if you're coming at this from a deontological ethic, that would not be good enough. If you're coming at this from a utilitarian consequentialist ethic, and that's your goal to end suffering, then either of these would apply. Those are two good ways to show the varied examples here. The circumstances, the situation, the patient is terminal, they're in pain and such and so on. The object, the what are you doing? If you give an individual morphine, and even if that morphine does hasten death, what you are doing is accepting the finality of death and just trying to ease suffering. If the person is euthanized, then that is what we call PAS, physician-assisted suicide, perhaps, and again, the idea is to end suffering. But both of these are distinct moral objects. In other words, the what, which is being done, is distinct from the intention. So you have to kind of keep this in the back of your head when you're working through things, and it's not always easy. This is why ethics courses are required, and people like myself study ethics, because this is not some sort of magic 8-ball, or that you can just shake and the answer floats to the top. It's not an algorithm you could put everything in. There's quite a bit to analyze, and not just analyze theoretically, but to almost delve, particularly depending on the ethical system. This might be even more so if we're talking about ethics of being and such. Now, okay, I laid that out so I can speak about this next thing. Now, the reality is that oftentimes an act, whatever it is that a person is doing, it has two effects, an intended good and an unintended bad. So, just for the sake of simplicity, let's keep to the moral object of hastening death. So an individual is terminal, they only have a few days to live, they have no longer eaten, they seem to be in a little bit of pain. So the choice is that we will increase morphine. The increased morphine may hasten their death. Now, I tried to say that falls under accepting finality of life and not euthanizing. But we have to admit that it does have an unintended effect. The good effect is to end suffering. The unintended is that it will hasten their death. So the principle of double effect, this actually came out of Catholic moral ethics. It was developed, at least articulated, by Thomas Aquinas. It's presented here because secular principlism has adopted it, and they've placed it under the idea of nonmaleficence. In other words, if something you're doing has an unintended effect, and the unintended effect is bad, isn't that doing harm? Well, no, and it's because of this. So what I will do is I will list the 4 criteria for the principle of double effect, and then we'll see if we can't just briefly apply them. First of all, the action in doing must be good or neutral. Okay. Oh, I should just say real quick that this originated like in an idea of self-defense. So if it's accepted that it is always bad to kill another person, let's use the word murder, then what do you do if somebody is trying to harm you, and in the process of you stopping them from harming you, they die? Does that equate murder? And the idea, no, it equates killing, but what you actually did was not kill that individual. That was the unintended effect. What your goal was, the object was self-defense. In other words, I was defending me and my children. And in the process of doing that, an unintended bad effect, that person who died. Okay? Now, before we start to have wild scenarios in our head, the good effect cannot be through the bad effect. In other words, my self-preservation may have persisted because that individual is bad, but just killing that person does not give me life. Okay, it was only necessary for me to maintain that life that I have, and it must be proportionate. So I'm not here to argue about various civil laws and ordinances. But if somebody were simply stealing your TV and they were on their way out the door and you shot and killed them, regardless if there's a legal aspect that allows that, that really would not be self-defense. It would be, defense of your property, but that's another issue. So in that regard, we may argue that it's not proportionate. The foreseen effect must be the bad effect must be foreseen, even if not intended. In other words, if you shoot somebody, you do know what is going to happen, or at least possibly will happen. You don't intend it. Somebody might say, yes, you did because you're pointing it. No, you don't intend to kill them. If we had a way to shoot them with some sort of, ray gun that would freeze them in that spot, then that would be satisfactory. But we don't have it, so we only can do what's at our means to do this. So, but you have to develop whatever this moral font is first. You have to know, what is the what? And then once you know what the what is, then you will ask, is it good or neutral? And now you can start looking about what your intentions are and such. So anyway, this is a way to apply to something when things have 2 effects. Another thing, just real simply, would be maybe to have a cancerous uterus removed. Okay, now that's not a good thing to have a uterus removed. So the unintended effect is that, this individual will no longer be fertile. But the good effect was, the good intention there was that they'd be at least free of the cancer. So everything that we probably get as far as treatment in one way or another has some sort of bad effect. Think of pharmaceuticals. But it's proportionate. So we wouldn't want the medicine to be worse than the treatment, something like that. Okay. Now, the last one on justice. Now, let's just say that, justice, typically speaking, is to give another their due. But this isn't doing what other people just simply want. That would be fulfilling desires. So I want you to think in terms of a triangle, and on the side of the triangle that goes from the bottom to the top point, let's call that legal justice. That's what all the individuals owe to the state. And then from the point back down to the flat part on the bottom, let's call that distributive justice. That then is what the state owes to all the individuals. So we have the benefits coming down and the burdens going up. The bottom line, this is commutative justice. This is like contractual things between us as individuals. The reality is that there are competing claims. Individuals need things, the state needs something from them, and then the individuals need things from the states, and then the individuals need things between themselves. So we have legal, distributive, and commutative justice, and there's always going to be some sort of competing claim between these things, which means that this is not always going to be an easy thing to apply. So you can think just in terms of allocation. How do you do justice? Like when during COVID, masks were hard to get and they were at a premium, they had to go to professionals and first responders first. because those are the individuals, literally the boots on the ground. That may have not seemed fair to individuals who themselves wanted them that weren't first responders, but in justice, you see, it's not fulfilling desires, it's giving them what to do, and what to do is they need them first. So we can't think about this as equal treatment, because when people think about equal treatment, they think that everybody has the same, and that cannot be. Any parent knows that they do different things for different children because different children simply have different needs. It's not simply as easy as they get older. When they were younger, you can say, okay, I'm going to spend $100 on each of my 3 children for Christmas. And then as they get older, they're going to have, one might go to school, one might find themselves pregnant. One might have gotten married earlier and just needed some help getting furniture. So it's not about equal treatment. So we always have this idea that we act and become what we value. Now, that sort of means that we become how we act and what we think is right, which means we're going to need some consideration on exactly what is this thing that we call ourselves, and what justice do we owe to ourselves, what justice do we owe to the state, what justice does the state owe to us, what justice do we owe to the individuals, and if you are a religious individual, what justice do you owe to your deity? Like everything, this conflicts with the principles. It's also that we live in this litigant society where when we want something, we call it a right. You know, the minute we frame it in right, that has a hard edge in our American constitutional system. So make sure that when we affirm or try to affirm a right, that we are not just equating those things with desires. If you remember in the natural law segment, I tried to make the case that rights are always connected to duties. So if I have a natural inclination to preserve my own self, then that means I need to preserve my life. I need a right to life. So we have to have rights connected to the duties, and then connected in that case to natural inclinations. If you don't accept natural inclinations, then you have to figure out where else exactly do I connect these two. Now, justice is never stable. There's nothing static about this. It's always dynamic, and it's always going to need some tweaking. So there's never a time here where we simply rest and say, now things are just. There's always going to be something. So back to John Rawls and his idea of justice as fairness, we can talk a little bit about something I didn't present earlier, the term reflective equilibrium. So this is more like a moral coherence, right? So we have these like moral intuitions. So we're always in our mind, we're weighing some principles that we hold according to some theories that we might think kind of apply in a particular situation, and we're trying to arrive at an adequate judgment. So we come to terms with it. We accept it in that regard. So this is more of an acceptance of moral coherence. Okay. Those are the 4 principles. Let me just real briefly speak about professional codes. And we'll call these practical guidelines. These are the things that you would see in hospitals and in clinics, and first responders would have them as protocol and such. The reality is that we always have to adapt to specific circumstances and the needs in society. In other words, in a situation where you might have somebody divulge information during a physician's visit, and let's say a psychologist, and the patient tells the psychologist that they are going to go and they're going to harm somebody. Right now, the professionals starting to think in terms of justice. What do I owe all other individuals? And they're also going to be thinking about nonmaleficence. I don't want to do harm to this individual. Primarily, I don't want to undermine trust. So they're going to have to start thinking in terms of how do I come up with this. Now, a lot of these things have been worked out in legal systems, but they've also been adapted through ethical analysis. So in the case of what to do if a patient's intending to harm somebody else, the medical professional, the very minimum, would understand, is their threat specific or is it general? It doesn't matter. It doesn't make it less important if it's general. It just means that if it's not specific, then that brings up the second concept, is if I'm going to break confidentiality in order out in the form of justice as a practical guideline to protect society from this individual who's going to harm somebody, not only since they didn't give me anything specific, the next thing is it even preventable? And also, are there any alternatives? So think in this regard that when a medical professional, a psychologist, is contemplating breaking trust because of harm that might come to the individual or themselves, you can't really get that back. In other words, let's be specific and say that they said they were going to go back to a school and they were going to harm somebody. We might have an immediate knee-jerk reaction. Now, I'm leaving out a lot of circumstances, so let's not try to form an ethical judgment just on the analysis that I'm providing here. But somebody might say, well, the professional has to do something because somebody's going to get harmed. Okay, fine. Then they divulge and they say, look, this individual is schizophrenic. They're not properly medicated. Now, that becomes public knowledge. It's going to become a lawsuit, too. Now, when people go to psychologists, they know that if they say anything that resembles an opportunity to create harm to other people, then that is going to be disclosed. So what will that do to the patient-professional relationship? The patient will know, I can't talk about this stuff. What that means in the end is that this contractual obligation between the professional and the patient, which is what I'm calling this professional code, this becomes undermined. And once this is undermined, what you're going to see is a lack of care for the patient. So what I'm calling a code, professional silence. Unless there's something specific, preventable, and there's no alternative, then the psychologist cannot disclose that this individual is harming some abstract individual. Because the reality is that, again, the care for the patient is the primary, and if trust is undermined and they don't think that they can have the professional silence of confidentiality, then that's going to really affect care in the future. All of this has to be brought out as the last gasp here for our ethical guidelines and such, is that studies have shown time and time again that medical professionals tend to adapt to the ethical climate upon where they work. That's not good. Well, it's good if there's a strong ethical climate. It's not good if there's a weak ethical climate. So every individual has to really show up and not just adapt to the form of what's going on, but they have to show up with their own ethical expertise. Let's put it that way. Nonetheless, these practical guidelines, if they are left at that, because they're, in a sense, guardrails, and we could say, okay, fine, it'll keep people on the road. But we also know that it's not just about staying safe on the road. We know that it's not good to ride in the berm, and a lot of tragedy can happen there. So we have to make sure, and this is at least my view of this, that all of principlism and all professional codes and protocols, they can't be it. They might be what is minimally required of everybody, but they're not going to make a good professional well at their job. And I don't mean that just as in it's their job, but they won't do well what they have basically been trained to do. So we can't let this devolve into, well, think in terms of this way if it helps. There are certain things that you can do which are unethical, but they're not illegal. So it may not be good that you do them, but you will not get into legal trouble. We want more than that from individuals who are treating us. If everything did devolve into that, now all we have is this dichotomy of providing care. In other words, it's just a service that's being offered. So this provider-consumer model arises. We want something a little deeper than that. Okay, so that's a real quick run-by on principlism and just a little mention of professional codes. In the next lecture, we'll be getting into moral dilemmas and issues properly. Thank you for listening.